Hello, my friends. Welcome to the live stream. Welcome to the Embodied Happy Hour, my friends. And blessings upon you this Thursday evening. How are you? How is your practice of embodiment at this moment? Are you feeling your body? Are you enjoying the autumnal flare of perhaps intermittent sunlight and perhaps increasing severity of elements? I certainly feel like I'm surfing a lot of waves and mostly enjoying it. My friends, tonight we are going to dive right into a topic of great interest to me as a clinician who works with folks with dysregulation of inflammation in the arm, and that is the sympathetic arm. We are going to discuss how the arm receives innervation from a major branch of the autonomic nervous system, that is to say, the sympathetic nervous system. And we are going to draw out, after mapping out that path, we're going to draw out some implications as to what this means if a person is having, for example, dysregulation of their blood supply in the arm, such as Raynaud's, or if a person experiences weird modulation of sensation in their arm, like complex regional pain syndrome, or like a regional increase in discomfort. Sometimes folks will have sort of altered healing processes or blood flow in the upper limb. And sometimes you just even have run-of-the-mill repetitive stress injury, which in which the sympathetic innervation of the arm is highly relevant. So why are we talking about the sympathetic arm? Because we care about the regulation of inflammation. At least I do. And if you also care about that, then you should keep watching, because something that I didn't know when I started being a practitioner of manual therapy is that the sympathetic nervous system is a key controller, a key modulator of inflammation in the body. We used to think of inflammation as a purely immune-mediated behavior, that's to say tissue damage or just a peaked immune system will generate inflammatory behavior. But why specific tissues? Why is someone inflammatory flares in this part of the body, not this other part? Well, it turns out, per Wilfred Yannick, and we'll reference this paper later, the inflammation, the sympathetic nervous system, both in terms of its evolution in our deep history and in terms of its embryology, co-developed with the endocrine and immune systems. And so the sympathetic branches of nerves are speaking a common language with the inflammatory cytokines. And as such, peripheral nerves play a huge role in orchestrating the tendency to inflame in specific tissues. And as we shall see in the arm, here I'll draw a little ball and socket of a humerus, terminating into an elbow, radius and ulna. As we shall see, there's all sorts of things happening down in the distal arm here, which our tendency, being musculoskeletally oriented and somatic nerve oriented, right? I mean, we make all these plastic models and look, all the nice, orderly somatic nerves. You can draw nice diagrams of them. You can memorize them. It is a bias in our educational system to teach toward things that are kind of comprehensible, right? That are kind of something that a teacher can get their head around. Well, look at this picture from Kuntz, 1927. This is a brilliant sort of depiction of a sympathetic ganglion on the front side of the spine. And in this case, we were talking about the stellate and middle cervical sympathetic ganglia. We'll get into what that means later. But here we once again see a revisitation of the nerves exiting the lower half of the neck, C5 through T1 nerve roots. These are the nerves heading out toward the arm. But in addition to this orderly row of somatic nerves, Kuntz and anyone interested in sympathetic innervation depicts another layer of nervous system ventral to these nerves, and they're arrayed along the front side surface of the cervical spine. This is where the middle and what we call the stellate cervical sympathetic ganglia live. And from here, these sympathetic ganglia send little spindly branches into the brachial plexus nerves, but in a way that is variable and hard to teach to sometimes. So, so check out this image once again. Kunz, 1927. I'll give you the link in the video afterward and in the chat. Here's that orderly row of nerves headed out to the arm. And here on the ventral aspect, toward the front body from these arm nerves, lives this very different character of peripheral nervous system. Notably, it's the sympathetic chain, a sympathetic trunk that dives down into the thorax. And as it ascends, it's this superhighway of sympathetic communicating nerves with the occasional thickening, which we now know is a ganglion. It's a cluster of gray matter in the peripheral nervous system, which is like a local magistrate doling out small orders, small regulatory changes to whatever nerve distribution it's about to send fibers into. And so the stellate ganglion, which is in the junction of neck and thorax, the middle cervical sympathetic ganglion, these are adjacent to these exiting somatic nerves and send this spray of fibers into them, headed out to the arm. This is where we get the regulatory influence on the tendency to inflame. So if somebody's got a tennis elbow, or a deep interosseous neuritis, or somebody's got a de Quervain's tenosynovitis, or a carpal tunnel, or a palmar irritation, we have historically thought, let's look at local musculoskeletal stress patterns and let's make sure there's no obvious somatic nerve stuff. But what if that person's nervous system has cranked up the knob of tendency to inflame in that distal limb? It's not on most people's radar, but the sympathetic nervous system's influence on inflammatory and autonomic processes in the arm is worth a moment of our time this evening. That's what we're doing tonight. Welcome to a kind of pop-up version of the Embodied Happy Hour. Always my hope, and most weeks my accomplishment, is to do this on a Thursday evening Pacific time. We're switching to a new time, which is 5 p.m. Pacific on Thursdays. So if you are any kind of body nerd, physical medicine practitioner, somatic practitioner, I welcome you into this live stream, and I welcome you to ask questions and say hello. So if you're watching right now, ye proud few who are watching live, feel free to comment, feel free to ask questions. This is your time as much as mine. Caitlin, welcome back. Thanks for the comment. Alas, I'm very sleepy. Well, I've often been accused of putting people to sleep. Maybe this is your go to sleep audio. It'll be Mike's Embodied Happy Hour / ASMR channel. And what we're going to do here is we're going to teach some anatomy. And we're just going to, talk about this nerve root here and then this other nerve root. Am I doing good for ASMR? Well, let's begin. Let's talk about the path of sympathetic nerves going from the body midline down the arm. And let's begin with a little bit of an odd surprise. Where would you say, if you had to guess and say, okay, Mike, I believe you, it's important for various reasons to care about sympathetic nerves in the arm. Where is the sympathetic nervous system that is concerned with the arm originating? Where is it originating? Well, okay, we take as a given that the main somatic nerves going to the arm originate between C5 and C6 and C7 and C8 and T1 nerve roots. And this together we call the brachial plexus, of course. and we have this plexification process, which then ends up descending the arm and forming these long familiar nerves like radial nerve, ulnar nerve, musculocutaneous, long thoracic, et cetera, et cetera. So there's our classic somatic nerves. And what we just discussed is that there's this other important layer ventral to the spine, we call the sympathetic trunk. And down in the thorax, it's relatively orderly. So sort of every spinal level, there's a kind of ganglion. There's a cluster of gray matter embedded within a larger superhighway of sympathetic communication. This is what we call the sympathetic trunk. And it sits on the anterior lateral vertebrae here, right at the costovertebral junction. And in the neck, it gets a little bit interesting. You have a superior sympathetic ganglion up here, getting information from below. Then you have a middle cervical sympathetic ganglion at C5, C6 area. And then at C7, you most often, in most humans, have a kind of megaganglion. And this megaganglion, when dissected, looks kind of like a star. So we call it the stellate ganglion. The stellate ganglion, meaning kind of a combination of lower neck and sort of upper thorax. So that's kind of a merged ganglion here. Okay, so we've got this vertical chain of sympathetic ganglia and fibers, and at each spinal level, there are little communicating connections that these ganglia have with their local spinal cord, right? All right, so what we know is that as we saw in that picture from Kuntz, show it to you one more time. The stellate and middle cervical sympathetic ganglia here, that spray of nerves, these are what are primarily contributing to the nerves of the arm. Importantly, this middle cervical is going mostly to C5 and C6, and the stellate is going mostly to the rest, C7, C8, T1, and sometimes T2. So this kind of spray is what we're looking at, but where do those fibers come from before they exist at these ganglia? So strange, so unexpected. Where is the brachial plexus? Well, it's between C5 and T1 in most humans. Sometimes a little spice of C4, sometimes a little T2, but you get the idea. So you might be forgiven for thinking that the sympathetic innervation of the arm originates from the cervical spinal cord. Not so. It turns out that you have to go down, not to T2, not to T3, not to T4, but between T5 and T7 to find the spinal cord origin of the arm's sympathetic innervation. So if you want to know who's controlling the inflammation in the arm, the blood flow in the arm, the reflex sympathetic behavior in the arm, it's this section of spinal cord. And I'll show you what I mean. So let's do a little sort of magical cross section here. And we'll go over here. And imagine I draw you a cut off spinal cord here with, imagine a sort of vertical cylinder continuing up and then continuing higher up from there. So we have a section of a spinal cord where really this is, half a centimeter wide or something like that. But we've blown it up, and then it's encased, of course, within a thoracic vertebra. And so that thoracic vertebra is this huge kind of bony body that exists around here. And then there's a sort of posterior part of that thoracic vertebra. So you've got this whole enclosure of the spinal cord here. in the mid-thorax. So we've taken a slice at T5, and we're showing you this kind of like this T5 level of the spinal cord. Okay. All right. If you look at any typical mid-spinal cord, it's going to look kind of like this. You're going to have a kind of H shape or an X shape here, with a little bulge in the middle of the H. This is basically the map of gray matter inside the spinal cord, cell bodies. So communicating matter is that kind of white matter, and then gray matter is sitting in the center of the spinal cord here. And the sympathetic nervous system is situated here. The sympathetic initial neurons here are sort of situated right here in the thoracic spinal cord. Stop me with questions if you have them. I'll try to keep track of those, okay? So feel free to comment. Aha, welcome, Michelle. I am very glad for your presence. And by the way, I'm going to talk about a case that involves this directly in just a minute. So stay with me. I know this is complex. It's worth it, my friends. It's worth it if you want to understand weird stuff that's happening in the arm. Okay. We know that there's a spinal cord inside a thoracic vertebra. So here I am drawing this big, bulky vertebral body. You know, I'm sure terribly, but here's a big, bulky vertebral body. Here is a rib coming out, attaching to the underside of the transverse process, and then sitting on the ventral surface of this vertebra is that self-same mid-thoracic sympathetic chain, right? So here, and here, and here, we have the sympathetic trunk. And so it's running up and down. When it comes to nervous system, the autonomic nervous system, we think in terms of fibers before the ganglion and fibers after, right? So in green now, we're going to trace what we call preganglionic fibers. So exiting from this level of the spinal cord, we have fibers that course around the body of the vertebra and come from the spinal cord into these ganglia here, okay? So I'm drawing this terribly, but you get the idea. Spinal cord into sympathetic trunk, okay? And in green, we call this, in the sort of forest green, we say these are called preganglionic. These are going from spinal cord into sympathetic trunk. And then from here, they're not actually staying here. They're actually taking that elevator straight up toward the neck. And sometimes there's some alternate paths that we might talk about, okay? But it's between T5 and T7 that the spinal cord sends signals into the sympathetic trunk, and then from here ascends the column until it gets to the stellate, middle cervical, and sometimes upper cervical sympathetic ganglia. Okay, why am I telling you this? Because we need to understand who's talking to these sympathetic originating motor neurons, because unless we understand what's causing these to fire at T5 through T7, we won't understand weird stuff autonomically happening in the arm. So essentially, there are two things influencing these sympathetic preganglionic motor neurons. There are descending signals from up in the brain, okay? So there are signals coming down from the brain and from other parts of the central nervous system, informing the actions of these sympathetic motor neurons. So they're sort of descending signals. Think of, again, as these preganglionic fibers as kind of like local magistrates trying to decide how much blood flow to signal, how much inflammation to prime, etc. Okay, and then also we have local inputs. This is so crucial. We have, in addition to these descending signals, if there is a sensory input coming from the local body, the somatic nerves, T5, T6, T7, into the dorsal horn of the spinal cord, it's these local sensory inputs that also influence the behavior of the sympathetic nervous system, T5 to C6. So we have descending signals and we have local sensory inputs. Can you see that? Maybe, maybe not. Local sensory inputs, okay? So there's your first takeaway, my friends. And I'll show you a much better drawing of this in a minute. But the first takeaway for the night is, if you want to understand a dysregulated sympathetic nervous system in the arm, you want to look first at the spinal cord between T5 and T7, allowing for some variation. And you also want to investigate, are there descending signals coming from the brain and brainstem that are informing the behavior here? And or are there local signals at T5 through T7 that are influencing the sympathetic nerve behavior? Case for you. I have a case of complex regional pain syndrome. A patient who used to be a musician and did what a lot of young musicians do, which is to practice well beyond the point of feeling okay in the arm. And so there was a persistent state of inflammation for a few years in this young person's life. And that tissue inflammation coexisted with a systemic state of autonomic stress. This was a stressful chapter of life. The guitar playing was the only escape from the stress, and thus it was worth it to this young person at the time to play and play and play long after it was appropriate from a tissue health perspective. But it was possible for a couple of years to just jam it out. And then it just became too much. There was intense swelling. The body was rebelling against this unceasing playing of guitar. Inflammation, neuroprotective behavior, sort of the arm became just like weak and painful and useless, and guitar playing no longer became possible. Person is a stoic person and basically said, I guess that's over. I'm going to go now and do grad school, stuff like that. But meanwhile, this arm became unusable for things like guitar playing and other similar activities of activating these flexors and kind of doing fine motor stuff with the hand. So unlike a lot of other inflammatory pain conditions, this patient of mine had weird autonomic symptoms decades later in the arm: inflammatory sensitivity, burning sensation, sweating changes in the skin, temperature changes, warmth and cold. And it wasn't in response to a specific loading or a specific gross motor pattern. It was this particular fine motor pattern. It was almost like the nervous system was recognizing the reattempt at playing guitar or doing something else, fine motor. That's when the symptoms came about. And so this is a classic case of complex regional pain syndrome, type 1, where CRPS, where there is a kind of not a tissue stressor, but almost like a behavioral sensory stressor that brings on a persistent symptom that lasts, minutes to hours in the arm. Okay. One thing that I noticed in this patient, which was fascinating, is that the symptoms had recently gotten worse, This was decades after the guitar playing. They'd gotten a lot worse of late. And one of the things that was notable about this person's body in the last months, in fact, one of the only potential drivers, is that this person was doing a lot more holding of a child. And as part of that kind of throwing kid up in the air, there was some injury and irritation to the fifth rib. And so here's a patient of mine who experienced, here, let me do it on the side, same as the diagram here. Let me get Rodrigo's arm for y'all. Okay. Can we borrow your arm, my friend? So, person comes in to my office. They have weird autonomic behavior in the area around the elbow and distal to the elbow on the palmar side. So burning sensation, hot, cold, sweating changes, and it's brought on not immediately, but over the course of a minute, minute and a half after initiating a fine motor activity with the fingers, okay? In addition to that, we know that it's been steady state for decades, except for the last few months when a new injury occurred, which is an irritation of the fifth rib here, where this rib is suddenly stiff and irritated on the same side. And so I don't actually know what's going on with this patient yet. I've only seen them twice. But my strong suspicion is that one thing that has recently increased the sympathetic drive into this limb is a mid-thoracic injury. Sensory inputs, local sensory inputs at the T5 level spinal cord may indeed, in this person with complex regional pain syndrome, may indeed have increased the tendency of these sympathetic ganglia to be activated and then for weird, complex regional pain stuff to occur because of this added load on the sympathetic stress. So I'm here for your questions, and I welcome them, my friends. But let me show you a better drawing than what I just have done. Let me see if I can find it. This is, again, from Wilfried Jänich. And the question is, what does it mean for a sympathetic ganglion to be fired? Well, historically, we have understood sympathetic motor nerves to regulate things like sweat glands and blood vessel diameter and local endocrine secretions. But there's a different way to think about sympathetic motor nerves, which is neural regulation of inflammation as well. Okay, so here's another cross-section of a spinal cord. And here's that little bulge, the sympathetic cell bodies of the spinal cord. And let's imagine this is happening at T5. What's driving behavior in these sympathetic motor nerves? Well, there are supraspinal pathways, in other words, descending signals coming from above, as well as incoming sensory inputs, that's the afferent inputs. And both of these inform the behavior of sympathetic motor neurons, which then send out fibers into the sympathetic chain, take the elevator up to the stellate ganglia, and all of a sudden you've got a new motor nerve, a new sympathetic motor signal traveling down the arm and terminating into specific tissue. Historically, we have not really recognized the tendency of the sympathetic nervous system to play a modulating role on inflammation per se. At least this was not part of my training. Well, this really changed for me a few years back with a beautiful journal called the Journal of Autonomic Neuroscience, published by Elsevier. And this was from May 2014, so I guess now 10 years ago. But the editor and the brilliant author by the name of Wilfried Jänich gave this great paper called The Sympathetic Nervous System and Inflammation, a Conceptual View. And the basic takeaway is that the sympathetic nerves can control inflammation in a tissue-specific way. And it's not the only factor, but it's a big one. Okay, so here's a schematic diagram. You've got central systems here in yellow, okay? You've got the motor system that controls muscles, that's the somatomotor system. You've got the sympathetic nervous system, and then you've got like neuroendocrine systems mediated by the pituitary gland. All of this is happening and talking to, and is getting regulated centrally from the cortical brain, from the limbic and brainstem systems, from sort of special sensory integration parts of the brain. And what's getting decided, among other things, is how much protective behavior should we be engaged in at any given time. And so when these systems perceive threat, they engage in a host of protective behaviors, one of which is inflammation, another one of which is sensory upregulation and muscle tone increase and heart rate increase, all responses to threat. But the real surprise is that the sympathetic nerves can do that somewhat locally. They can do it regionally. Okay, so this is the brilliant part of Yannick's hypothesis here, is that we can think of local tissue inflammation is at least partially actuated by sympathetic nerves. I think I've made that point. So questions, my friends, while we are cognizing this, and then we'll kind of follow the story a little bit further distally as we proceed here. So Michelle says, love this. I'm always sore at C7, myself as well. So soreness, in the shoulders. Yes, indeed, persistent inflammation in the upper limb. One should be thinking not just about reducing mechanical stress or improving stability, or improving sort of somatic nerve function, but is there anything we can do to calm the local segmental or the systemic sympathetic nervous system behavior? In other words, unless you are helping to calm the sympathetic motor response, your other strategies may not be that helpful. Okay. So Dubois says, can a muscle stim TENS unit work around T5? It's a great hypothesis. One thing you could think is, hey, I want to downregulate the threat response at the sympathetic motor nerves T5 through T7. And so what am I going to do? I'm going to bathe the local nervous system at T5 and T7 in pleasant or innocuous sensory inputs. It's a worthwhile experiment if you've got somebody with arm sympathetic dysregulation to think about the kind of mid-thoracic spinal region and all of the sensory inputs going into this level. And so don't get too married to T5 to T7. I promise you that people vary in exactly which levels are influential here. But suppose that you're interested in affecting arm sympathetic behavior, you could do worse than to target this section of the thorax and just try to give them very pleasant, compelling stimulus there, whether it's e-stim, whether it's manual therapy, whether it's self-massage, whether it's breath, whether it is rib movement, right? And so not just the back here, but everything associated with sensory input at the spinal level, lungs, heart, diaphragm, etc. Anything you can do to bathe this mid-thoracic sensory system in non-threatening stimulus at the same time as you're enacting a social ritual that feels safe and kind of like a good transformative container. That way you're taking care, at least ritually, of the central nervous system. So CNS safety, local sensory input of a saturating and innocuous or pleasant variety, that's a decent recipe for at least temporarily calming the sympathetic response. Put a heat pack on there. Put some Tiger Balm on there. Whatever may work within sort of the bounds of clinical your clinical scope of practice. It might be something worth trying. And so this is my current strategy with this patient with complex regional stuff in the arm, is to try to work with an eye toward the different levels at which the sympathetic nervous system is being dysregulated in the arm. And so for people with dysfunction sympathetically in the arm, one option that is sometimes recommended by physiatrists and pain physicians is to take this stellate ganglion, this mid-cervical sympathetic ganglion, and do an injection here, do a nerve block injection here at the stellate, here at the mid-cervical sympathetic. Essentially take the last precipice of gray matter in the nervous system before these nerves jump off and join the arm's brachial plexus, and do a nerve block right here and right there, and knock out the sympathetic motor signal to this dysregulated arm. And quite often, that is at least diagnostically useful, and sometimes it is therapeutically very useful in two ways. Number one, it gives a dysregulated sympathetic system a pause in the sort of severest of symptoms. And number two, sometimes being shown a non-crisis state so that the nervous system recognizes this as territory that it can inhabit is helpful. It's kind of putting a there for the nervous system. So sometimes people say, well, are you interested in temporary therapies? Don't knock the temporary relief, because a nervous system that has been persistently irritated and dysregulated for years might find a temporary relief revelatory insofar as it proves that this is a state I can inhabit, this is a sensorium that I can have, and maybe one method there is a nerve block at my stellate ganglion, but another might be the slower and more persistent re-regulation of my sympathetic nervous system. So it's complex. There are endocrine and nutritional and behavioral and sensorial ways of influencing these sympathetic pathways, but along the way, it might tell us something useful to do a nerve block. Not that I'm going to be the one doing it, but sometimes it's a useful diagnostic and possibly a useful therapeutic agent to do a temporary block to see what changes when the sympathetic ganglia are kind of tamped down in their sensation. So my interface with the phys med world is just say, great, you can get this block or not. Meanwhile, I'm going to try to do my work of re-regulating your descending signals as well as your local sensory input in the thoracic spine. And then just kind of walk the path down the arm. Anecdotally, it's remarkably effective to actually just put your fingers on the sympathetic ganglia of the neck. So you can do it with me, my friends, if you like. You can find your sternocleidomastoid muscle on either side. And you can take your fingertips, and rather your finger pads, and I want you to put the pads of your fingers on the back side of this SCM muscle, okay? So find that muscle, that big surface muscle on the side of the neck, and just rest your finger pads like a water bug resting on a pond on the backside of this muscle. Okay. Now, if you go to the lower half of your neck and then gently sweep the muscle forward, your fingertips now will land on a denser muscle that's one layer deep. That dense muscle, deep to the SCM on the anterior neck, is the anterior scalene. Anterior scalene is running from C3 to C6 here at the neck, and it's descending to the first rib. Use that anterior scalene muscle as your map now, okay? So now I want you with your fingertips to explore toward midline on the front surface of that anterior scalene, okay? And you won't get very deep, don't worry, okay? If you're gonna be right on this anterior scalene here, my finger is the anterior scalene, you might be right here, you're gonna explore toward midline, staying in contact with the scalene. You won't get too deep because you'll run into a fascial barrier, which is the prevertebral fascia of the neck. That fascial layer is kind of here, it's encasing the sympathetic nervous system above and below. And so prevertebral fascia you can think of as a fascial layer that encases the deep flexor muscles of the spine, as well as anchors the sympathetic chain. So here you are running into this ventral fascial layer on the front of the spine, behind the throat, but in front of the spine. You can follow the anterior scalene in. Well, when you do this, sweep the SCM gently forward, land on this anterior scalene, migrate inward. From there, on the surface of the scalene, your fingertips are now in contact with the sympathetic trunk. Okay, your fingertips are now in contact with where that stellate and middle cervical sympathetic ganglion are nestled there. And wouldn't you know it, sometimes when you put your fingers here, you'll notice blood flow changes in the hand. Wouldn't you know it, you put your fingers there, you'll notice autonomic changes. I've noticed that when I work here, sometimes there's a change in sweating in the limb. There's a change in skin color. There's a change in blood flow, in other autonomic behaviors. I haven't tracked if people's hairs stand on end, but perhaps that too. Strangely enough, just speaking anecdotally, working at these ganglia, maybe it's blood flow modulation, I don't know, seems to also produce some perturbations of the sympathetic nervous system in the arm. To what end? Who knows? But when you have complexity, the downside is you're not always sure what's happening. The upside is there's lots of ways to affect the system. So one way is intrathoracically. Another one is at the neck. Another one is just to follow these brachial plexus nerves down along their path, make sure there's no sites of irritation, inflammation, circulatory stress on the nerves of the arm traveling down the line. Because that, my friends, is another way to maintain a sympathetic state. If you maintain a state of privation, of stress upon the nerves of the arm, that's also sympathetic stress. It's just distal to or rather down the line from the sympathetic ganglia. Okay, so just to go from a little excerpt from my upcoming class on thoracic outlet syndrome, I want to show you a layer of fascia, this prevertebral fascia again on the front of the neck, and I want to contextualize what we're seeing here. Okay, so here's a little excerpt from my handout and from the class. I'll post a link to this upcoming class. If you're a manual therapist, you're welcome. And here is a cervical spine with, brain and dura above, spinal cord in light blue descending, and then in the cervical spine, you got these scalene muscles coming off the spine. The same anterior scalene we just probed. Now we ran into this, what I colored in green here, this prevertebral fascia, in which the brachial plexus forms its bundle headed out to the arm. But also, if you travel around to the front here, this is where the sympathetic chain gives contributions to the brachial plexus, okay? And then from here, you go further down into the armpit. Now this is the trapezius, the collarbone, the subclavius. This is the first, second, third ribs. You're looking from the side, but also up at the neck here. It's almost like you're looking up into someone's armpit. And this is what you see. I won't make you do it to me too long. You see the trunks of the brachial plexus inside the neurovascular bundle. Well, by this time, the sympathetic nerves are traveling alongside the trunks, and they're embedded within these fascicles. And if you have a state of cyclical inflammation in the long nerves of the brachial plexus or the arm, that too can be a sympathetic dysregulation. That too can lead to perhaps somewhat simpler, but still autonomic dysregulation, such as in classical nerve entrapment, carpal tunnel, thoracic outlet, cubital tunnel syndromes. These are not just pinches of nerves. They are autonomic and inflammatory dysregulations. And unless you learn how to calm down that sympathetic ecology, you're going to be a lot less effective when treating nerve entrapment. That is my contention, at least. Okay, so my friends, questions now. We're sort of getting to the end of my live stream for tonight, but I feel I feel like we've covered some interesting ground. I hope it's been helpful. I will link you to some research papers in this discussion. Thank you for attending this kind of pop-up version of the Embodied Happy Hour. I'll do a better job promoting it next week. Michelle shares, I think my client is local. That's to say, my client's sympathetic dysregulation is local to the thorax, not from the head, not descending regulation. Decades of owning horses, needed shoulder surgery, but she refuses surgery. Again, someone with a lot of pain and discomfort in the mid-thorax. So maybe that's contributing to arm sympathetic behavior. Michelle, you are definitely the champion of commenting today. Thank you for that. You wanted me to explain about nutrition. Well, I'm sorry, I'm not the expert. I can say that there are pro-inflammatory foods and there are pro-sympathetic food behaviors, shall we say. So if your glucose levels are fluctuating a lot, your sympathetic nervous system will not be as well regulated. If your histamine levels are being spiked by the food you eat, then your sympathetic nervous system might respond in a dysregulated way. So this is a very complex physiology, and I'm not the person to have the nutritional discussion, but I want, when we are navigating sympathetic behavior in the upper limb, we want to do something that is cognitively a little bit difficult. We want to think about the real anatomical pathway of the sympathetic nerves on one hand, but we also want to think about the sympathetic nervous system in a network of communication with other body systems, the immune system, the endocrine system, the digestive system, and of course the other nervous system parts, the cortex, the limbic system, the brain stem. All of these are like political entities that are jockeying for control over this defensive behavior here, right? And it's all about maintaining homeostasis. It's all about achieving a safe and economical equilibrium for the body. And when a person is disequilibrated, a person is dysregulated, our job is to find out which part of this complexity, if we work there, would get the most benefit, right? That's the ecological question. Where is the most benefit going to happen in this world? The last thing I'll mention about this interesting story about T5 through T7 spinal cord signaling, going to the sympathetic trunk, climbing up the sympathetic chain into the stellate and mid-cervical sympathetic ganglia, and then from there, splaying out into the nerves of the arm, is that it's not only the arm that is receiving sympathetic innervation from these lower cervical ganglia. It is also organs in the upper chest cavity. It's also sort of descending sympathetic fibers plexifying through the chest and even into the diaphragm. So when you are asking a person about sympathetic behavior in the arm, like changes in blood flow, changes in sensation, changes in inflammatory state, changes in sweating and hair and sort of like hair motor behavior, all that stuff. Also ask them about heart rate changes, breath rate changes, senses of tightness or expansion in the chest, changes in the esophagus and the upper GI. These are also receiving sympathetic innervation from the same ganglia at the neck, albeit from somewhat different spinal cord levels. So there's another layer of complexity for you. Don't ignore the viscera that are co-innervated by those same sympathetic ganglia. All right. Thanks, Era. Thanks for the compliment. It was fun. It was a bit kind of yeehaw, just get going, go live. Kind of, Bill O'Reilly, screw it, we're doing it live today. No worries. Michelle, thanks for all your comments. I hope that our sort of pondering of the predicament of your patient has been somewhat helpful. Standard disclaimer, I don't know enough to make specific recommendations, but I hope we've sifted something of value. Anyone else watching, if you're watching it live, you're watching it later, please comment, please share. I will do my best to respond to your questions and comments after the fact. So even though I'm logging off now, if you send in your comments, I'll check back tomorrow and try to answer your questions. This is such a crucial area, and I found that, whatever value you've gotten from our discussion today, if you have an arm, a shoulder, a scapula, an elbow, a wrist that is persistently inflamed in weird ways, that is experiencing Raynaud's syndrome in a bothersome way, that is experiencing complex regional pain or blood flow disturbance, or whatever else that feels autonomic in the arm, this is so crucial to spend a little time with, because it's here where the regulation of sympathetic tissues in the arm occurs. And it's here at the mid-thoracic spinal cord and at the cervical sympathetic ganglia where we have the best chance of influencing that sympathetic behavior, whether our tool is a loving hand, whether our tool is an injection nerve block or an e-stim or whatever else your tool set is, guided visualization, worth putting on the map, my friends. I will give you a link to a couple of the peer-reviewed papers that went into today's discussion. This a class for manual therapists on thoracic outlet syndrome, carpal tunnel syndrome. We'll be touching on this sympathetic behavior in that class, which I'm very excited. I've been teaching that class for like 17 years now, so it's always different. It's always worth it to teach, at least, and hopefully to attend. And if nothing else, my friends, please consider joining me again on a Thursday, 5 p.m. Pacific, for the Embodied Happy Hour. It feels like a nice piece to communicate with and something I'm still learning how best to do. Thank you for your presence. I'll catch you later, and feel free to ask questions. Thanks.